Hello, hi, I'm Dr. Francis Cyran. I'm an orthopedic surgeon, and today I'll be talking about knee replacements and the different types, total and partial. Just a bit about me. Cyran, I work for Mercer-Bucks Orthopedics. I'm an orthopedic surgeon. I do total joints, complex joints, primary joints, meaning first-time ones, and revision or redo joints, ones that have failed or had problems, infections, etc. I also do other things and was board trained in musculoskeletal oncology, which is limb salvage, bone and soft tissue tumors, so cancer in adults and children, etc. I started my career at UCLA. I'm a tenured professor there. I was there for 15 years. Also was the chief of the limb salvage service at the Veterans Hospital there as well. I did fellowships at UCLA in musculoskeletal oncology and total joints. I did my residency and medical school here in New Jersey and Newark, at Rutgers, and then college at Johns Hopkins, and then grew up in New Jersey. I'm a member of the Academy of Orthopedic Surgeons, hip and knee surgeons, as well as the Musculoskeletal Tumor Society. So just a bit of background on total knee replacements. Approximately in the US, there are 1 million per year. That's a lot. So by age of 50, roughly 1% of the population has had a knee replacement. By the time you reach 80, almost 10% of the population has had a knee replacement. Average age of a knee replacement is about 64 years of age. We've done them as young as 40 or younger, depending upon circumstances. And I've done them as old as patients as 95. So age really isn't an issue. It's more about how healthy are you and other factors. So a bit of background, why do we do knee replacements? The most common cause is for osteoarthritis. That's basically wear and tear, kind of like your tire on your car wearing out. And that's the number one cause. The number one cause of excessive wear and tear is overweight. So when people are overweight from any reason, be it obesity from fat or extra muscle, the knees see approximately 5 to 10 times body weight with bending. So every 10 pounds that you gain, your knees will see 50 to 100 pounds of extra force across them. And conversely, when you lose 10 pounds, your knees will see 50 to 100 pounds less force. So it makes a huge, huge difference. Trauma and secondary damage from that also is a cause of this. There is another factor as well, something called rheumatoid arthritis. That's an autoimmune disease where the body attacks the joint lining, and then subsequently from that, the knee is destroyed. So we can replace and repair the damaged bone, but the cause that attacks the soft tissue lining is still there, and some patients may still have some pain after knee replacement. So in terms of what is your knee, it's a complex multi-center joint. So there's motion in between your femur or your thigh bone and your tibia, which is your shin bone, and also a joint between your femur again and the patella or your kneecap. So we have just a few illustrations of that. We can see the white cartilage covering. We can see the muscle up here, the red, turns into a tendon, it turns into the kneecap. And then inside the knee, there are some other structures as well, which can hurt. One is called the meniscus. It's a little C-shaped cushion. You have one on either side of your knee. They can be torn and cause pain while your cartilage is undamaged. So there's a lot of things that can kind of cause some pain or function problems in the knee. Just another view of that. So in the knee, it has several ligaments in it. There are 2 on either side that control the bones that keep them from moving apart, as well as some little ligaments that cross in the middle. And those are typically taken out during a total knee replacement, but not always. So knee pain is a funny problem. Knee pain is often not just from the knee itself. Knee pain can be from the knee, but it also could be from the back and or the hip. So the knee pain itself, just from talking about the knee, we have a couple pictures on the top right. That's an example of what damaged cartilage can look like. And then the series of the bottom will have some sideways views of the knee, with the left shot being a normal knee, with the middle one showing some wear and tear of the cartilage. And the shot all the way on the right is when we're talking about rheumatoid arthritis, and that's the condition, autoimmune disease, that attacks your joint, and that still be present even if we replace the knee. So when I talked about knee pain can be from other parts of the body, that's called referred pain. You may have heard about that when people have a heart attack and they have some pain in their jaw or down their left arm. It has to do with how the nerves formed when we were developing as a fetus, and the nerve signals get a little crossed up, etc. So hip pain often can run down to the knee. You can have hip arthritis, which can be felt in the knee and not necessarily have any hip pain. Also, I just made a diagram of some of the muscles that can hurt and be damaged and cause pain at the knee. So even though you may be having pain in the knee may be fine, and it may be some pain from a damaged structure elsewhere that's causing that. My own chairman of my last department kept on having knee pain. They're x-raying his knees, not seeing anything wrong with it. And he goes, oh, of course, I'm an orthopedic surgeon. Why didn't I think of this? Took an x-ray of his hip. He had bad hip arthritis. Replaced his hip and his knee pain went away. So sometimes it's a funny thing, and that's our job to figure it out for you. In addition to that, besides the hip, knee pain can be from the back. So I have here an example or a picture of the drawing of all the nerves that come out of your spine and run to the different places in your leg. Some of the nerves go and control the muscles, and some of them are responsible for pain. And how the body works is that if you trigger that nerve anywhere along the path, the brain isn't smart enough to figure out that the nerve is triggered on the path. It just knows that if that nerve is triggered, that means that there's pain in that area. So if you squeeze that nerve that goes down to the toe, anywhere along the path from the spine down to the toe, you're going to have toe pain, despite the toe being absolutely fine. So for the knee, if you herniate a disc in your lower back, the lumbar spine, say around L2, 3, 3, 4, between the different vertebrae, and that nerve goes down to the knee, then you may have knee pain there, despite the knee being fine. So again, that's our job to try to figure that out. So here's an example of the knee. Now the knee is a complex joint, which we mentioned before. It's not just like a hinge that just bends back and forth along one point. So when you bend your knee, the knee actually slides back and it rotates, and it does some funny things. And that's what all those ligaments do. And there's a lot of little structures and muscles in there that control that. It's a complex motion. Unfortunately, our knee replacements are not that sophisticated, and they can't reproduce all of those motions. So as a result, some of the bone, some of the muscles, the ligaments, the tendons, they tend to fight against it. And often the pain relief from a knee replacement is not perfect because your knee moves slightly different than it did originally. So on the right of that picture is kind of an example or schematic of what a knee replacement looks like. The grayish substance is a metal cap that we put over the end of the bone, on the thigh bone, the tibia, on the femur, and there's a little plastic part in between the two parts that lets it glide. So how do we treat osteoarthritis or just knee wear and tear? Typically, we want to see a patient have failed conservative therapy before proceeding with a knee replacement. So typical conservative therapy, meaning non-operative therapies, would include weight loss. Again, I remember I mentioned that 5 to 10 times body weight the knee sees. So weight loss is often a very successful way of reducing or eliminating pain from knees. I've had a few patients with horrible bone-on-bone arthritis everywhere, were very heavy, lost 100 pounds, and they didn't even want surgery afterwards because the knees hurt so little. Exercise is actually a very good way to help in reducing pain. Most studies show that some sort of non-impact exercise, so walking, swimming, stationary bike, about 5 times a week seems to help with pain in terms of stabilizing the muscles. And we've definitely seen that after COVID, where a lot of people stopped walking for their jobs, et cetera, and everyone's arthritis pain went through the roof. And once we got them back exercising again, it calmed down. Other treatments involved can be injections into the knee. There are different types of injections. I'll go into that later. Typically, you've heard about cortisone shots, and then the gel shots or the rooster comb shots. Those are the 2 main ones, and there's some other ones as well. And last is medicine. Typically, we talk about NSAIDs or non-steroidal anti-inflammatory drugs, like you've heard of Motrin or Aleve, ibuprofen, and then there are prescription versions of that. These are non-addicting drugs, meaning that they're safe. You can drive a car, you can operate heavy machinery. They don't cause you to be sleepy. You can have a glass of wine with it, etc. So, and they're well tolerated by most people. And there are even some cream forms in that for some patients who can't take them for various other reasons. So typically, once a patient has failed conservative therapy, meaning we've tried all those things, we've tried the shots, the exercise, the weight loss, bracing, which I forgot to talk about, none of that works, and then we typically talk about pain. So people who benefit from a knee replacement have pain that interferes with their quality of life. It interferes with their activities of daily living and their walking ability. So basically, the question you have to answer yourself is, does it hurt bad enough to want a surgery? And if you do have visible signs of damage on an x-ray, then most patients benefit from that and that they're happy from it. Conversely, patients who have a lot of pain but don't have many x-ray findings, I'm not talking about MRI, just plain x-ray, they don't seem to do well with knee replacements and often have worse pain after a knee replacement. And unfortunately, I see those patients as second opinions from time to time in my office or done by other surgeons. And they just don't do well. So unless you have visible signs of arthritis on your x-ray, I would suggest not getting a knee replacement. And most of the studies now back that up. So MRI is a different thing. That doesn't seem to correlate well with the surgery. So there are different types of knee replacements that I'd mentioned before. One is a total knee replacement, and then there's also something called a partial knee replacement, where we replace one side. And then there's also something called a patellofemoral replacement, where we just basically replace the kneecap. So for a total knee replacement, this is a sideways view of some of the different bony cuts that we have to make. Basically, what we do is we find your knee, we find a size that matches it, and we make all these special templated cuts with special gadgets that align it down to less than 1 millimeter precision. And then we replace it with the different components there. There's probably about 150 steps to doing a knee replacement. There's a lot of things to look after in these. So this is an example of what a total knee replacement would be. Typically, you do a total knee replacement for arthritis in more than one spot of the knee. So typically, we divide the knee up into 3 different spots. We talk about the inside portion, where the other knee is. We talk about the outside portion on the outside portion of the body, that's lateral, and then also between the kneecap and the thigh bone. So if you have arthritis in more than one spot, then we recommend a total knee replacement because that's what works the best. For patients who just have limited wear and tear on just the inside or the outside, typically the inside portion of the knee is the most commonly worn spot, then you're a candidate for a partial knee replacement. And I have some x-ray pictures over there on the right. So on the top picture all the way to the right is what a normal knee looks like. There should be some space in between the bones indicating that there's a sufficient amount of cartilage that it has not been worn away. On the bottom picture, there's a little arrow pointing to where you can see the bone touching bone, and that's wear and tear there. But on the outside portion, it may not show up well in this webinar, but there's a sufficient amount of space there. And then there's some cartoon drawings just to the side of that. So this would be a candidate for a partial or unicompartmental one compartment knee replacement. Last knee replacement is something called the patellofemoral or kneecap or arthritis. And that's mostly for arthritis just between the kneecap and the thigh bone. So we have some pictures there where you can see basically there's a picture on the top where your knee is bent and we're looking through it. And then there's some sideways views down below showing some examples of what a normal kneecap looks like all the way to the left. And then as you get further and further to the right, more and more arthritis. This is not terribly commonly done. Typically, most patients, when they have bad arthritis in that spot, they typically develop it elsewhere. So this is not a commonly performed procedure. This is just what a patellofemoral arthritis implant looks like. So there are some pictures on a mock skeleton there on the right. Basically, we cut a little groove, we put a little metal cap on it, and then we put a little, we cut the kneecap in half, we put a little plastic covering on that to insulate it, kind of like shoes are on your feet. So there are some x-rays there on the bottom left, what that looks like. It's not like I said, not a commonly done surgery. So we always are very cautious about referring those for patients because we want to make sure that we're doing the right thing for you. A lot of people ask what knee replacements are made out of. They're made out of typically several different compounds. The femoral component, the part that goes on the thigh bone, end of the thigh bone or femur, that's typically made out of an alloy called cobalt chrome, very, very tough and hard. The tibial component or shin bone component, that's typically made out of either titanium or cobalt chrome. And then that plastic part in between the two is made out of a hardened polyethylene that's specially X-ray hardened, etc. The kneecap is sometimes covered by surgeons and sometimes not, and that's also by that same plastic component. There is one specific manufacturer that makes some components without these compounds. They make it out of their own brand of metal without nickel in it, and we use that for patients with nickel allergy, etc. So those are some of the things we ask patients about for surgery. These are generally non-magnetic. You can go through an MRI and have it done. You're not going to get sucked into the machine. You can go through airport security. It may set it off, it may not. You tell me I had a knee replacement, they wave a wand over you, and that's about it. They don't care if you have any cards or anything. They're not going to care because anyone can print up a card nowadays. So knee replacements, a big question that you always should ask yourself is how long are they going to last? So we always take into account and factor the age of the patient before we do this because we seem to think that they'll probably last about 15 to 20 years, maybe a little bit longer. Roughly 80% of all patients still have their original knee replacement in after 20 years. So if you're 40 when you're getting it done, then there's a very good chance that you'll need to have it redone and redone again as it's going to wear out, and every subsequent surgery is a more difficult surgery, etc. So there are some things that go into the wear and tear of these in that lifespan. That plastic part is typically the part that may wear out after 20 years, but there are other things that happen. Some people get infections, from an ingrown toenail or a bad tooth, but typically that's only about 2% of all knee replacements put in over a 20-year period. Another 2% break them from falls or other issues. And then there's some other problems in terms of mechanical failure, dislocation, where the knee pops out of the socket, etc. And these are fairly rare. So generally, if you get your knee replacement in, you want to get it done once. So, hold off as long as you can. Most surgeons will say, keep your own knee as long as you can until you can't stand it, and then we'll put it in. So you want to get that down the road so that you have one surgery, you don't have to worry about it again. Some differences between the partial and the total knee replacement. So the total knee replacement I talked to you about probably lasts about 20 years for most people. The total knee replacement is a painful surgery. I've had many women say it hurts worse than childbirth, etc. We certainly do have better pain control medications nowadays, etc. But it's a painful surgery. And it's not a surgery I operate and you get better. I operate and you need to do a lot of physical therapy. It takes most people about a year to get used to their artificial knee. It doesn't quite feel like their regular knee. As a long rehab, many patients can never kneel on their artificial knee again because it hurts. It doesn't damage it, but it's just uncomfortable, and so many people just can't do that. So something to consider if you work and have to do stuff on your knees or garden, you may not be able to do that afterwards. The advantage for a uni or partial knee replacement is that it's a much quicker rehab. It moves like a regular knee because we don't cut out those ligaments. We just leave them alone. It allows you to be more active. Generally, recovery is much faster, works better, etc. The downside is it may not last quite as long. So if you get, say, a partial knee replacement at age 65, there's a 10% chance that you may have to have it redone. And those are pretty good odds. So we try to put a partial knee replacement in the patient if they benefit from that, but if we see extra wear and tear, then we'll always go back to the total. Hip replacements, many of you have had hip replacements as well. We pretty much consider that a perfect surgery. Many patients have the hip replaced and they forget about it. They don't even know which hip was replaced. Knee replacements aren't that good. They're good, but they're not perfect like that. Roughly 12% of the patients, 1 in 8, still wind up taking some pain medication after the surgery, despite everything looking perfectly. The artificial knee is permanently bigger than the other knee the rest of your life. That's just how they look. I talked about the kneeling. There's roughly an 80% satisfaction rate. I think that's somewhat tainted by the fact that there are some patients out there who have their knees replaced and probably shouldn't have had it done. They probably didn't have enough wear and tear on it, and they're unsatisfied with that. So I tell patients, it's not a perfect result. If you have this much pain before the surgery, you're going to have this much pain. So you still have some pain. It's a lot less than before, but it's not like the knee you had when you're 20. But it allows you to walk, you can bike ride, and, some people can play tennis with it. You can certainly run and catch a grandkid if you need to prevent them from doing something silly. But most people want some basic things out of it, that they can walk, etc. And so as long as we have those goals in mind, then most patients are satisfied with them. So why do knees hurt? We talked about that before. When you have arthritis, it's a loss of the protective cartilage. So most people have had chicken and you see the end of the bone, it's white and shiny. Well, that's your cartilage and it's nice and thick. As we age and get past 20 or 30, that cartilage, despite being thick, sometimes develops cracks in it or little chips in it, and so it starts to wear and tear. And eventually, once you wear through all the cartilage, that's when it really starts to hurt and it inflames the bone. So I liken it to wearing a pair of shoes on your feet. If we pretend that the shoes are the cartilage, you can wear a pair of shoes and walk on gravel and it doesn't hurt. But if you get a hole in the sole and walk on gravel, it tends to hurt. So that's what that cartilage covering is like. We don't have a good way of regrowing that as of yet. That's been our holy grail in orthopedics for as long as I can know or remember. But we don't have a great way of regrowing cartilage yet. So stem cells and all those things do not work well on that. So anyway, so that's why we prescribe anti-inflammatories. So when the bone becomes irritated or injured, it becomes swollen, and the anti-inflammatories help reduce the swelling, which reduces the pain, and it works quite well. Again, I'm just mentioning the conservative treatments here. We talk about exercise. That's one of the best things. Probably 5 days a week, some sort of exercise is better than 3 days a week. We'll talk about the anti-inflammatories, Aleve, Motrin, etc. Now, Tylenol is not an anti-inflammatory. You can take in addition to that, but it doesn't relieve any inflammation or swelling in the bone. We talk about the steroids. They're a different way of reducing the swelling, and then weight loss. There are some other treatments that you may hear: glucosamine, chondroitin sulfate. These are these supplements. There may have been one initial study that showed some sort of benefit from that, but all the subsequent studies have really found no successful relief of pain or deferring of knee replacements in patients. So the biggest study that I know of, they had something like 20,000 people, and they gave people either a sugar pill or the chondroitin glucosamine supplements. They didn't tell them, they kept track of all their pain, and the glucosamine or chondroitin supplements were no more effective than the sugar pill. So if you want to take them, that's fine, but I would say don't spend a lot of money on them. You're likely just not doing much for that unless you're satisfying some sort of placebo effect. Stem cells are talked about a lot nowadays. They tend to be quite effective. I've seen costs ranging anywhere from $4,000 to $9,000. Most of the studies show that they can regrow a little bit of a certain type of cartilage, not the cartilage typically found on a knee, but that the effectiveness is only seen on very mildly effective knees, and it's temporary. Most patients, in terms of rating their pain relief and how long it lasts, found it it's no better than a $30 cortisone shot. The $30 cortisone shot is typically covered under insurance. The stem cell is not. So save your money or save your parents' money. I would not spend it on that. We don't have any benefit as of yet. There are some different growth factors. Most of the studies aren't really showing any terribly effective methods for that or relief from that. There may be some very mild benefits from it, but nothing long-term that's going to prevent arthritis. So what does arthritis pain feel like? Typically it's pain in the area of the knee, although many patients complain of tightness in the back of the knee, and that's from the swelling up inside the knee. Typically, arthritis pain is pain with activity that limits your walking. Because the pain is generated from the rough surfaces rubbing on each other, it tends to be pain with motion. Typically, people with very bad hip or knee arthritis, when they're not walking or not using or moving their legs, it doesn't hurt. Knees that have arthritis will often lose motion. They'll become stiff. They may have a bend in them where they don't straighten out fully, and they may tend to swell up a lot. And then some people develop some arthritis so badly where the knees actually will bend in. You'll see them become bow-legged or knock-kneed or something like that. When we see patients that say, my knee hurts all the time, even at rest, they can walk a long distance, that's a clue telling us that it's probably not the knee, that more likely it's some sort of referred pain from the hip or the back, etc. Typically, nerve pain hurts all the time. Many people describe it as a burning or needle or electrical sensation, etc. In terms of knee replacements, there are different ways, slightly different ways of doing them. The main approach is just a straight cut down the center. If you go to the beach, you'll see a lot of people with them once they're past retirement age. There are some other buzzwords they talk about, minimally invasive, etc., robotic, you may have heard about nowadays. I've done the robotic courses, and I did them a long time ago, at least 10 or 15 years ago. As of now, they have no proven clinical benefits. They do cost more. They do need extra radiation in order to get the computer model. But in terms of patient outcomes, meaning pain, function, redo scores, etc., there's been no benefit as of yet. So most of the time, it's an advertising thing for us. I've taken the courses, I do them, but it does involve more time, slightly more time, and slightly bigger incision, etc. So take it for what it is. There are some different types of knee replacements as well. Most of them are glued in, but there are some knee replacements that actually are relying on the bone to grow into that. We will do that for certain patients if their bone stock is good, typically younger patients. You may hear about minimally invasive approach, where people make a very tiny scar. Again, there's no benefit from that. In terms of muscle damage, it's exactly the same. In terms of recovery times, they're exactly the same. Unfortunately, they have a higher revision or redo rates because you can't see what you're doing necessarily, and sometimes the components are in a poor position or you don't take all the things out. So you're going to get a surgery, you might as well have the surgeon be able to see what they want to do and make sure that they get all that stuff in the right area, in the right spot, so it works better. So typically the incision is probably about 7 or 8 inches long, and that's fairly common. That's my talk on the knee replacements. If you have any questions, I will go through them now. First patient says, I have severe arthritis, double meniscus and bone spur. Bone spurs, yes, I forgot to mention that's a common finding on arthritis. It's a byproduct of arthritis. The body makes extra bone to help stabilize it, and that's a sign of arthritis. We've tried before in terms of trimming those bone spurs, removing them, or smoothing out meniscal tears in the face of arthritis, and they don't offer any benefit to patients. Often patients wind up having worse pain after they recover and often need a knee replacement sooner. So we leave those bone spurs alone, and generally those. Arthroscopic surgery, again, is not recommended in the face of arthritis, so we will not do that. I did discuss PRP injections. These are some of these cell type of injections. Again, they seem to offer minimal benefit in terms of long-term, etc. Someone asked, do we have ligaments cut during the knee replacement? During the knee, a knee has typically 4 ligaments, 2 on the outside, and then there are 2 in the middle that crisscross. Most surgeons take out both of the ligaments in the middle, and there are still some surgeons that leave one of the ligaments in the back. There are pros and cons to each. One is not necessarily clearly better than the other. Someone has a tibial plate from a previous fracture. That's a fairly common thing. So you have post-traumatic arthritis. I wind up doing a bunch of these every year. We take out the plate. Occasionally we can leave it in. And we often can just do the knee replacement with that in the area. We just have to make a funny incision sometimes to try to get everything. Outpatient joint replacement safe in a surgery center, yes, for the right patient. We want to make sure that you tend to be a healthier patient, though we are operating a lot of Medicare patients now, and they're doing just fine. I've done over a couple hundred by myself. I think our practice has done, I don't know how many, at least now getting close to 500 or 1,000 outpatient, and they seem to be just fine. Patients tend to get better when we operate in a surgical center because they go home, and they tend to be more active at home as opposed to sitting in the hospital waiting for the physical therapist to come around. Someone asked a question about genicular artery embolization. That has been effective for some sources of knee pain. So some patients who have knee pain, we will wind up sending them for that attempt to control their knee pain, especially when they have minimal evidence of arthritis. Someone's asking about pulling pain in knee when you sit cross-legged. If you're not having pain when walking on it, you probably don't have significant arthritis. You may have a stiff muscle. Again, it's hard to answer that question without seeing you. Someone asked, what locations do I see my patients in? We have an office in Langhorne, Pennsylvania, and I'm mostly in New Jersey. So I see patients in Lawrenceville, Princeton, Hamilton, and then also in our Monroe office. Someone asked about double knee replacements. I will do them on certain patients. They tend to be much riskier than single knee replacements. So there are some specific criteria for doing that, which I usually go on a patient-by-patient basis. But there are some very significant severe risks in terms of complications, blood transfusions, going to rehab, blood clots that go to the lungs, etc. It is generally best to get one done. And when that knee is a good knee, then get the other one done. And that's how I would tell my mom and dad to do it. That's how I would do it personally, unless they had met certain specific criteria, etc. Pain management center. Yes, we have pain management doctors here that often can take care of that. So we wind up doing a lot of shots in knees for many years, and they seem to do just fine. When patients get down to bone-on-bone arthritis, there aren't many things that will make it better other than getting a knee replacement at some point. Some patients do fine with it. Again, we don't tend to operate on x-rays, we operate on the patient. So, if you're not having much pain, despite showing bone-on-bone arthritis, then we leave it alone. But if you have a lot of pain, and then our job is to control the pain, it gives you a good quality of life. And if that fails, then we talk about knee replacement. Nerve ablation to the knee, that's kind of covered under the genicular artery embolization. That usually gets taken care of at the same time. Unloader brace, that's one of the conservative things that we talked about for managing milder arthritis. That tends to be for our younger, more active patients who have arthritis limited to one spot in the knee, etc. Someone's asking about plica in their knee. That's probably more of a sports orthopedic surgeon's area. Well, they will put an arthroscopic little camera the size of a pen in the or pencil in the knee and can take care of that. Ask what exercise is good for the knee. Everyone has different wear and tear problems with their knee. They wear it in different areas. They use it in different areas. So there's no one particular exercise that's good for everyone's knee. So a non-impact exercise. So I suggest try walking, try swimming, try bicycling with the seat low, with the seat high, elliptical machine, whichever one hurts the least, feels the best. That's a good one for your knee. Someone asked about referred pain, burning. So typically burning pain, that's often a nerve issue. So I will usually wind up sending those patients for therapy first. If that takes care of it, good. If not, refer them to the spine doctors where they can talk about MRI for their spine and visualizing that. Baker cysts in the knee, that's a very common finding. It's basically when the knees become irritated, the knees make extra fluid, and that extra fluid needs to go somewhere, and it typically goes out the back of the knee. And it occurs in such the same location all the time that Dr. Baker had it named after him. And that's a very common finding. It's just it's a reflection of the arthritis in the knee. So taking the cyst out, for most cases, doesn't do anything. The body will tend to reform it. Typically, the Baker cyst will go away once we do a knee replacement. And sometimes it can be lessened if we do a cortisone shot into the knee. So I think that's all the questions. I have to get going and see patients this afternoon. So today, have a good day.
Thank you, Dr. Cyran. If anyone has any questions about this particular presentation, please feel free to email me at programs@mbortho.com. I will consult with Dr. Cyran and get back to you. Also, if you'd like to make an appointment, please feel free to go to our website at www.mbortho.com or call 855-896-0444. We thank you all for spending your afternoon with us.